Uh, Good afternoon, good morning, everybody. And today we are going to have a webinar. I welcome you on behalf of the All India Ophthalmological Society Scientific Committee. The title of the webinar is From Concept to Clarity, and we are going to be talking about the new generation of the refractive intraocular lenses. And we have with us an esteemed speaker, Dr. Dan Black from Sunshine Eye Clinic, Australia. And he's a very high volume surgeon. And he's going to be talking to us about clinical outcomes of next generation refractive extended depth of focus intraocular lenses. So, over to you, Dr. Black, for your talk.
Thank you for that introduction, Dr. Sharma. This is my colleague here, who is actually the designer of the lens, and I'm going to invite her to speak first so that you have an excellent understanding of the technology behind this lens.
Thank you, Dr. Black, and thank you, Dr. Sharma. So indeed, we thought it would be nicer if we start with the concept, so that we can go to the clinical, to the respective clinical.
Perfect.
Great. Very good. So then, my name is Aixa Alarcón. I work for Johnson & Johnson, and I work in the design of new intraocular lenses. So today is a pleasure to be here with all of you to explain and to introduce to you our new technology in the extended depth of focus category. As you may know, Johnson & Johnson introduced the first extended depth of focus in the market with Technis Symfony. So today I have the pleasure to talk to you more about what is the new innovation in this same category. And before we start with what is new with this design, I would like to remember what the benefits that we are keeping because we have a Technis lens. And Technis is a platform, a family of lenses that has been in the market for more than 20 years. And it has three important advantages respect to competitor lenses. The first one is the optics. Technis was the first aspheric IOL that was designed to fully compensate for the spherical aberration of the cornea. And that means better contrast for the patients, especially in low light conditions. The other benefit is also the material. The Technis lenses are made of the sensor material, and it's a material that, for example, has very low chromatic dispersion, which is also going to improve the quality of the vision of the patient. And the last one is also the mechanical platform. All the Technis design has the same geometry, and they all have the same equally good mechanical stability. And that's also very important when we go to the toric lenses. We know that our toric 2 lenses, they have more rotational stability. So that is what the starting point for this design. So now I'm going to introduce you our new extended focus intraocular lens. It's the first purely refractive EDOF lens of the Technis family. And it's based on a continuous change in power that is designed to extend the depth of focus, but minimize the visual symptoms. So the anterior surface of the lens is the same than other Technis lenses. It has this asphericity to compensate for the spherical aberration of the cornea. And what we have done is to modify the posterior side of the lens. So we have optimized this posterior side to meet three design goals. The first design goal is to have this photopsia profile comparable to a monofocal IOL. That means very low level of visual symptoms like halos, starbursts, or glare. The other design goal was to extend the depth of focus. We want to have a lens that's going to deliver high quality intermediate and the functional near that is so characteristic of an EDOF lens. And the final design goal was to have very good distant image quality, very good contrast, and that also means high tolerance to refractive errors, to any small amount of defocus of astigmatism that the lens can have, that the patient can have after the surgery. So with these three design goals, we came with this totally new technology. So what we have done to achieve this goal is to modify, as I mentioned, the posterior side of the lens. We change smoothly and continuously the curvature in the posterior side, and I hope you can see here. So we change the elevation in the posterior side, and you can see here how it compares. This is the monofocal IOL, that has a same curvature through the posterior side of the lens. Therefore, you have one single focus at the end. And then you have here Technis PureSee, and it has this smooth chain in curvature through the surface of the lens. This is going to change the power profile of the lens, and that's what is going to elongate the focus to get better intermediate and near vision. And maybe to understand better how this lens works, let's start with a monofocal IOL. In a monofocal IOL, all the rays that go through the cornea and through the intraocular lens, they are all going to focus in one single focus. They will create at the end a spherical wavefront, and because all the rays are perpendicular to that wavefront, they will all go to one single focus here. That's the distant focus, and that's why monofocal lenses have very good distant vision, but of course they will have a blurred intermediate and also near. With Technis PureSee, what we do is we are going to modify the curvature. We are going to create this power profile, and as you can see here, by modifying the curvature in the posterior side of the lens, by modifying the elevation, we are going to modulate the wavefront. So it's no longer a perfect spherical wavefront. We'll have rays that are going to go to a wider range of distances. So we'll have rays that will go too far, we'll have rays that go to intermediate, to near, in a continuous and smooth way. So that's how we created the elongated focus. And that's how the lens is going to deliver better intermediate and better near. And before we go, I would like to mention that this chain in elevation in the posterior side of the lens is fundamentally different of what you can see with a diffractive IOL. In diffractive IOLs, and you can see the illustration here in orange, these diffractive rings are visible in the elevation profile, like very sharp and abrupt changes in elevation. But that's fundamentally different of what you can see with Technis PureSee, where the elevation just changes smoothly and continuously through the posterior side of the lens. So this means that with Technis PureSee, we have a purely refractive technology. It doesn't have zones because the power chain continues smoothly through the surface of the lens. It doesn't have a defined at power. It doesn't have also diffractive rings or any abrupt chain in elevation. So basically what we have done is to reduce all the possible sources of these photopsias to the minimum level. That's how we achieve that monofocal-like dysphotopsia profile. And additionally, by creating this elongated focus that you can see also here in the simulation, we can achieve better intermediate, better near, but also you can see that beyond the far, we also extended the range of vision to have that higher tolerance to refractive errors. So everything I'm going to provide today, I would like to give you some highlight of how it works optically and also clinically. Everything is already published, and of course, Dr. Black is going to give you more information about the clinical performance, but I just want to give you a highlight of what you can expect with this design. So the first was to start with the optical performance, what we can measure in the optical bench. So what you can see here, these are the focus curve measured in the optical bench. You can compare the Technis monofocal IOL in orange, Technis Eyhance that we know is around 1 line better than the monofocal lenses, and then you have Technis Symfony and Technis PureSee, that is the light blue. And you can see there how Technis PureSee delivers superior intermediate and near vision compared to the monofocal lenses, and even better, and of course better than Eyhance as well, and to the level of Symfony. What is really unique in this design is the dysphotopsia profile. In the right side, you can see Technis Symfony here. Symfony is a lens that already delivers better dysphotopsia profile than a multifocal IOL. But you can see that when we look in worst case condition, and this is our picture collected in an optical bench, you can see how there are still very clear halo and glare around the main image. And that's create like a reduction in the contrast and this not blurred, but veiling luminance that we see in lenses with an increased scatter. I hope you can see here that going from the left, from the Technis monofocal to Eyhance to Technis PureSee, they all have equally good dysphotopsia profile. And Technis PureSee just look like a monofocal IOL when we look at the dysphotopsia profile in the optical bench. But the main advantage of TECNIS PureSee is, of course, you are going to get the range of vision of an EDOF lens, but what you gain, not only the low dysphotopsias, is the quality of the distant vision. And that is very important if we compare, for example, with other lenses in the market of the same category. There are other lenses that share this refractive or non-diffractive category. And you can see here that the main benefit of implanted at TECNIS PureSee is going to be the quality of the distant vision. And a way to quantify this is looking in the optical bench to the MTF. The MTF, that is what you perhaps have in the left figure, is a measurement of the quality of the contrast of the image. We have measurement in 3 millimeter pupil size, like simulating a photopic pupil, and we also have measurement in 5 millimeter, simulating a mesopic pupil. So what you can see there is we compare TECNIS PureSee to other lenses in the same category like BBT or LuxSmart. You can see that PureSee delivers superior image contrast for both pupil sizes, ranging between 20% respect to BBT in photopic, but even go to higher, like 36% in the mesopic lens condition. The other advantage of the design is not only it can provide better image quality for distant vision, also the pupil independency. And that was illustrated in the figure in the right. When the pupil opens from photopic to mesopic lens condition, what you can see is with PureSee, the image quality is maintained. You have almost no change in the quality of the vision. And that's something that doesn't happen for other intraocular lenses. We did a head-to-head study comparing TECNIS Eyhance to TECNIS PureSee, and I would like to just show you some of the outcome that we got from this design. Because the main difference between TECNIS Eyhance and TECNIS PureSee is going to be in the superior near and also, of course, intermediate vision. And this is what is illustrated in this figure. So in the left, you have TECNIS PureSee compared to Eyhance in the same study, and also to some historical data of ZCV. And you can see that the best corrected intermediate vision at 6 months monocular is superior to that of the TECNIS Eyhance IOL. But what is really characteristic of this design is that not only intermediate vision is better than Eyhance, it's also you get more consistent outcomes. And that's what is illustrated in the right figure. That is the standard deviation, which indicates the variability between the different patients. So you can see that PureSee is going to deliver better intermediate vision than Eyhance and also more consistent outcomes. And the best of all is maintaining the good distant vision of a monofocal IOL. And these are best corrected distant vision, monocular at 6 months, and you can see how TECNIS PureSee, that is the first in the left, is at the level of the monofocal lenses. Also, the clinical data confirm the profile, the monofocal-like dysphotopsia profile of TECNIS PureSee. Here you can see the frequency and the level of bother of halos, starburst, and glare. And you can see that both lenses, Eyhance and PureSee, deliver the same dysphotopsia profile, with clear majority of the patient don't seeing or not bothered at all by these dysphotopsias. The other advantage of TECNIS PureSee is what we already discussed, is the quality of the distant vision. And that's something else than the visual acuity. We can measure that also with the contrast sensitivity, and especially when we go to the worst case condition, that is low luminance level. And that's what is illustrated here. This is the contrast sensitivity in mesopic with and without glare. And you can see how there is almost no difference between the Eyhance and the PureSee IOL. And we think that is precisely this high quality distant vision what is going to enable the high tolerance to refractive errors of this design. And I'm going to go very quickly through this slide because it's a study that Dr. Black did, and we are lucky to have him here today. So just very quickly, some of the outcome we see from this study is that thanks to this high quality distant vision, the lens is going to be more tolerant to a small amount of defocus and astigmatism. What you can see in the figure here, these are simulations in realistic eye models when we evaluated the uncorrected distant vision with plus minus 0.5 diopter of defocus and also 0.75 diopter of astigmatism. So what you can see is that PureSee is at the level of the monofocal lenses. And that's better than Symphony, which was already quite good and is known because it was very tolerant, especially to astigmatism. That's what you can see here with the high bar in orange. But when we see that PureSee already delivered a benefit, especially for myopic outcomes compared to Symphony IOL. And of course, significantly better than a multifocal IOL. The other benefit is that tolerance to refractive errors not only happen for the visual acuity, also in terms of these photopsias. We can see, maybe it's not very clear here, this is the simulation of the PSF, of that is photopsia profile, for plus minus 0.5 diopter of the focus. And I hope you can see in the simulation that the monofocal, Eyhance, we know it's no different respect to the monofocal, and Tecnis PureSee, they all provide the same, this photopsia profile. And this is different of what we see, for example, with Symphony, that we know that for the case of hyperopia, it's very nice and very comparable to a monofocal, but then for myopia, you can start seeing a halo. And of course, they are all of them better than the multifocal lenses. So because of this good range of vision, the high quality of distant vision, and that tolerance to refractive error that deliver more consistency in the outcome, what we see also in the patient from this study is that they have high satisfaction. So you can see here in the left, the satisfaction of the patient with their distant vision, the intermediate vision, and their overall. But something that I would like to mention as well before I finish the presentation is that to keep in mind that because the lens is so tolerant to refractive error, sometimes can be also difficult to know when you are in the correct refraction. And that's something very important, maybe for the patient, is not going to notice the difference, but for yourself, you are going to start using PureSee. It's important to keep that in mind, especially you want to know the true performance of the lens, or if you want to optimize your A constant. And to illustrate that, what you have in the figures, these are clinical defocus curve. You have the monofocal, you have Symphony there, and as you can see, there are two light blue for PureSee. The solid one is from our clinical study. You can see delivers superior intermediate and near vision compared to the monofocal IOL. But the dotted line is a subgroup of patients where we really push for having the correct maximum plus refraction technique. And by doing that, you can see how there is no change in distant vision. The distant vision is equally good, but you gain in the range of vision. So that's why, considering the technology of the lens, knowing that autorefractors cannot be used, we strongly recommend to use a proper maximum plus refraction technique to really understand the performance of the lens and to get a correct A constant if you want to optimize that. And also talking about the optimization and the A constant and also the IOL power calculation, I would like to give you some advice about what we are recommended if you decide to go and start using Tecnis PureSee. So one of the recommendations is, of course, use the new generation formula for IOL power calculation. The other very important recommendation is use the labeling A constant. Don't use your personalized A constant because it can depend on the lenses that you're using, it can depend on your own experience. So we are recommending just use the labeling one, the default A constant for the platform, and then go for the first minus. Just treat the lens as a monofocal IOL. So go as close as possible to emetropia, but always go for the first minus to achieve that emetropia and still deliver the best performance, the best true focus performance of the lens. So I would like to finish here, and I think we have time for questions as well. I'll be happy to answer any question, any technical question that you have. I will be happy to answer that.
So thank you so much. I think that was a great presentation. It actually cleared all the concepts of not only the PureSee, but also other lenses that you talked of. And I know that you've done some great contributions to the designing of Eyhance, which has changed the way we practice our intraocular lenses. Dr. Praful Marana is there. Praful, would you want to ask a question? I just wanted to know, of course, I'm sure Dr. Black will be telling us, but where do you place these lenses in the, the fact that PureSee has come up? I've also implanted a lot of PureSee lenses and they are giving very good results. But then I'm sure you would know where to do, I mean, which sector Eyehance would be more useful, which sector Symphony may be more useful, and which sector do you think Pure C is going to be more useful? Or do you think it is just based on the economics that would decide which patient, which lens the patient is going to choose from?
That's a great question, Dr. Sharma. So maybe what we can do, I would want to give the technical perspective in this answer, and then I will let also Dr. Black to talk more from the clinical perspective. So from the optical, purely optical perspective, we have to think that they are two totally different categories. Technis Eyehance was designed to be a monofocal plus, so to keep just a slightly improvement in intermediate vision. But Technis Pure C is a totally different design. It comes to deliver high quality intermediate vision that you need to qualify as an EDOF lens. And probably you are also familiar with all the standard, the new ISO standard for simultaneous vision lenses, and also the ANSI standard. So Technis Pure C was designed to meet those goals. And that's something we know that Technis Eyehance doesn't meet. So we are talking about totally different category of lenses, one just slightly better than a monofocal, the other one is a presbyopia correcting lens. So we expect that we'll get more from that. But
okay. So I think I would invite Dr. Black to give his talk now with the huge amount of experience that he has with all kinds of lenses, and with a high volume practice, I'm sure we are going to become wiser.
So thank you for the introduction and the opportunity to share with you my experience. During the COVID pandemic, the proof of concept study was conducted over several sites in Australia and New Zealand, and I had the good fortune to implant the world's first Pure C lens. And since that time, we have had it available commercially in Australia for about 8 months, and I have implanted close to 500 of these lenses now. So presbyopia. Can you advance the slide for me, please? So presbyopia, when we are young, we take accommodation for granted. When we are young, we take accommodation for granted. It does not interfere with our ability to be active in the world and play sport like the king here himself. But as we get older, past our 50s, presbyopia begins to become an impost on our lifestyle, and our dependency on spectacles for close work can become frustrating for people. Patients don't like presbyopia. Patients want presbyopia correction, but there are some barriers. As surgeons, we're worried about the quality of vision from a presbyopia correcting lens. We don't want to reduce contrast sensitivity. We don't want to induce dysphotopsias. And if a patient is paying more for a presbyopia correcting lens, the last thing that we want is for that patient to become dissatisfied with the result. So I thought it might be useful to look at some of the causes of patient dissatisfaction and how that fits into the context of this new technology. And the two main causes of dissatisfaction are dysphotopsia and blurred distance vision due to uncorrected refractive error postoperatively. So let's look at both of those factors. So dysphotopsia. Here is a study published in December last year, looking at an analysis of 2,500 patients that had results uploaded to the RayPro website. And the analysis is that dysphotopsia was strongly correlated with patient dissatisfaction. Now, halos typically originate from the optics of the IOL, but there are other contributing factors such as tear film instability, such as posterior capsular opacification, vitreous syneresis, as well as uncorrected refractive error. So we need to keep all of these things in mind when we're trying to manage the the dysphotopsia problem. This is a slide that Aisha has shared with you before, which shows the Tecnis Pure C in the center there compared with the monofocal on the left. And even in the presence of uncorrected refractive error, even in the presence of defocus, the Pure C has a very similar dysphotopsia profile to the monofocal lens. The quality of vision outcomes for the Pure C. And you can see here that for the vast majority of patients, they had very little dysphotopsias and were unbothered by it. And my own clinical experience over the last several hundred patients, and I see them all myself at 1 month postoperatively and ask them all directly, are you having any issues with your nighttime vision? Do you have any problems with night driving? And universally, the answer is no, doctor, I have no trouble at nighttime. My vision is very clear. Uncorrected refractive error causing ametropia is one of the biggest causes of patient dissatisfaction following implantation with a presbyopia correcting lens. And there will always be 5 to 10% of patients with some degree of postoperative refractive error due to variations in the tear film, inadequacies in the formulae predicting effective lens position, and there will also be patient-centric factors beyond our control. One of the great qualities of the Pure C is tolerance to refractive error. And what that means is, even though you may have some refractive error, you can still have well-preserved, uncorrected acuity. I want to share with you the results of the study that we performed. The proof of concept study was a group of 120 patients. 60 were implanted with the Pure C lens and the control group with the Eyhance lens. And of that group, half the patients had some degree of refractive error after surgery, more than a quarter of a diopter. So 31 in the Pure C group, 29 in the Eyhance group. So let's look at this subgroup of patients now. So you can see on average that these patients had around 1/3 of a diopter of spherical equivalent error and about 1/2 a diopter of astigmatism, but ranging up to 0.75 diopters. And we look at their binocular, uncorrected distance acuity, and 97% of these patients are seeing 6/7.5 unaided. And as a consequence of that, when we ask them, have you been using distance correction in the last week? None of the patients with Pure C were wearing a distance correction. They were all spectacle independent for distance tasks. And you ask, how is this possible? And it's due to the underlying high contrast acuity. Aisha presented these slides earlier, and I want to reinforce their importance, that shows the contrast sensitivity from the Pure C is essentially the same as the contrast sensitivity of the Eyhance. And I know many of you here in India have had experience with the Eyhance and you're familiar with the high quality vision that it delivers. And Pure C builds on that high quality vision. So these are the MTF values of a series of lenses taken through a 5mm pupil in polychromatic light. And you can see here the Tecnis Pure C on the right-hand side, this dark bar here, and you can see that the MTF value is not quite as high as the Eyhance, but what you can also see is if you look at these other monofocal lenses, you can see that the Pure C actually has better contrast sensitivity than some monofocal lenses. And then if you look at some of the other lenses in the EDOF class, again, you can see that Pure C has a significantly higher quality of vision than its competitors. And I think that's the reason behind its success. So PureSee builds on the visual quality of Eyhance, but it adds to that almost 2 diopters of presbyopia correction. I want to share with you some case studies which you might find instructive. So here is what I always think is a very difficult patient. Here is an active man in his late 50s who, prior to developing cataract, had been emmetropic and using a presbyopic correction. But he's developed nuclear sclerosis cataract with a 2 diopter myopic shift. And he's in fact enjoying the fact that he's no longer presbyopic. But at the same time, he's very frustrated with his blurred distance vision and his very poor nighttime vision. So this is always a difficult patient. If we put in a diffractive presbyopia correcting lens to preserve his near vision, he's not going to be happy with his night vision. If, on the other hand, we put a monofocal lens in to give him good, clear night vision, he's going to be frustrated at his loss of presbyopia. So enter the PureSee as an option. So I proposed to him bilateral PureSee. The right eye was the worst of the 2 eyes, so we started this one first. I hope you can see on the screen here that I've targeted the first minus, and I've implanted the closest toric lens, the DET150, and it is important to not only correct the sphere, but to neutralize the astigmatism as well. And post-operatively, he's 6'6" with a minus 050 sphere. So we target the second eye as close to emmetropia. We put in a DET100 toric lens, and he's 6'6" plano. So he now has a half a diopter of monovision. He reports to me excellent night vision, no problems driving at night. He has a pair of reading glasses that he pulls out of his pocket and says, "Doctor, I've worn these twice in the last week. I'm very, very happy. You've worked a miracle." And of course, it's not really me that's worked a miracle. It's the miracle of the optics of the lens. So here's a couple more challenging cases. This is a 75-year-old man who'd had previous PRK and arcuate keratotomies, and he had those in 1995. There was no history available. And to make matters worse, he had dense amblyopia in the fellow eye with the best corrected acuity of counting fingers. You can see from his previous corneal surgeries, he's had some higher order aberrations. He has some corneal irregularities. So I've used his total K values in the Barrett True K formula, which is available on the ASCRS website. And it predicted a post-op a spherical equivalent of minus 0.3 sphere. I've implanted the toric lens, and post-operatively he's had a little more myopia than had predicted, but this is a post-refractive surgery case, and so this is not unexpected. And this is where the tolerance to refractive error really comes to my aid as a surgeon to give a satisfying result. So firstly, he's absolutely delighted with his uncorrected near vision, and he can read the smallest of prints with ease. What surprised me was he also reported clear distance vision. His uncorrected acuity is 6/9 part, and I put it to him. I said, you will want a pair of glasses for driving, certainly for night driving. And he said, "No, doctor, I don't. My vision is very clear. I have no problems at all. I don't want spectacles." And that really surprised me. But it's a great example of the tangible benefit of tolerance to refractive error. Here's a second instructive case that I want to share with you. And this is a woman who'd had previous LASIK for myopia 20 years previously in Denver, Colorado in North America, no history available, but she had an epiretinal membrane. And you can see here the OCT pictures of the distorted foveal reflex. So I gave her a very guarded prognosis. I said, I think surgery will make you only 80% better than you are now. And I think there's a high probability that you're going to need a vitrectomy and epiretinal membrane peeling. So again, I used the total K values in the Barrett True K formula, implanted a toric lens, and you can see here her uncorrected acuity is N8. And on the first day, post-operatively, she's in my office and she reaches over and picks up my reading card and she says to me, "Doctor, I know I'm aware of the distortion from the macula, but around that, apart from that, the vision is actually really clear. I can see really well." And that really surprised me. But this is a practical example of the benefits of a lens with high quality contrast sensitivity. And in fact, she said to me, "Doctor, I want to schedule my other eye straight away." And I said, "Well, let's let this eye settle and see you in a month." But it really surprised me how passionate she was about the clarity of her vision despite the metamorphopsia. So I want to share also with you some pearls so that you can get the best out of this new technology. And there are a few nuances to understand. Firstly, ametropia is our enemy. It blurs the distance vision and it also amplifies the possibility of dysphotopsias. So we really want to correct the sphere and neutralize the astigmatism. The cornerstone of doing this is having excellent biometry. And we think of biometry, we think of keratometry as some measurement of the radius of curvature of the cornea. And that's not true. Keratometry is a measurement of a reflected image from the tear film. What's absolutely critical is tear film optimization. And here's a case that really brought it home to me. So this is my patient. This is two sets of biometry on exactly the same patient. The one on the left was performed before tear film optimization, and the one on the right was exactly the same patient performed 3 weeks later after tear film optimization. And you can see that if we'd taken the initial biometry, we would have had a spherical error of greater than 1 diopter and a toric error of almost 1 diopter. So what we do now in our practice is we send out a small package to the patients with some preservative-free lubricants in it and some instructions to start 3 weeks before their appointment to apply hot compresses to the eyelids morning and night to address meibomian gland disease and to instill preservative-free lubricants 3 times a day, including the morning before their appointment. When they arrive in the office, the very first thing we do, before we take a history, before we test their acuity, before we put any drops in the eye that will disrupt the tear film, the first thing we do is we take them into the room to have their biometry performed. And I think if there's only one pearl that you take away, it's about tear film optimization. Obviously, most of us are all using some kind of modern 3rd or 4th generation formula. And despite the latest formulas, there's always some inaccuracy with calculating effective lens position. But use the formula that you're most comfortable with. Of course, we all should be auditing our results. We can't progress as clinicians unless we audit our results. And auditing cataract surgery, particularly after using a lens like the PureSee, we have to have a very accurate post-operative refraction. Autorefractors do not work. You have to use a maximum plus refraction. It's easy to do, it's not time-consuming, but it will give you invaluable insight into the performance of this lens in your own patients. To give you one example, when we started doing the proof of concept study, this is a very rigid study and we followed the guidelines to the letter, and we uncovered 1.3 1.6 diopters of presbyopia correction. But we went back and retested the patients using a maximum plus technique, and we uncovered an additional 1/3 of a diopter. And so if you're not using a maximum plus refraction, you may well underestimate the final outcome by 1/3 to 1/2 a diopter. So I really encourage you to instruct all of those technicians who are doing the post-op refraction to do a maximum plus refraction. And as a consequence, I've now personalized my A constant to 119.6. Having said that, you should start with 119.3, audit your own results with the maximum plus refraction. And I want to give you some guidance about targeting. There are two groups of patients. There are the emmetropes and the hypermetropes over here, and then there are the myopes over here. And we have to use a different targeting strategy for those two groups. Let me share with you why. This is a great paper published by Giacomino Savini and Ken Hoffer, and it gives us some guidance with targeting. So this was a paper using a mathematical model. They looked at calculating the near point for a multifocal lens with a 2.5 diopter add. This table looks quite confusing, but let me take it through it. So down the left-hand side, you can see the dioptric measurements of the cornea. And down the bottom here, these numbers here represent axial length. So let's take a patient with a 48 diopter cornea and a 30 millimeter axial length. That patient with a multifocal lens with a plus 2.5 add is going to have a working distance at 72 centimeters, which is about 10 centimeters beyond my arm's reach. Conversely, if we then look at someone with a 39 diopter cornea and a 20 millimeter eye, so this number over here, we can see that their working distance is going to be at 53 centimeters. So from someone who's very hyperopic to someone who's very myopic with the same lens add, there's a 20 centimeter difference. So for hyperopic eyes, you can target much closer to planar. If you're putting in a 25 diopter lens or higher, you can go much closer to planar. But if you're using a lens like plus 15, plus 12, plus 10, these myopic eyes need more minus. You really need to target the second minus. So to sort of sum up, PureSee really has all the benefits that the Eyehance has or the monofocal has. It has high contrast daytime vision, high contrast nighttime vision, just like a monofocal would. But paradoxically, it delivers nearly 2 diopters of presbyopia correction. And it is nearly 2 diopters. I mean, it's not 2.5 or 3 diopters. It's about 2 diopters. So that's also important when you're aligning patient expectations. It has this tolerance to refractive error. And as a consequence of that, mini mono vision works really well with a 1/2, maybe 3/4 of a diopter. And that helps just to bring it in from 2 to 2.5 and can help to reduce the need for spectacles. It delivers very high satisfaction levels. And in my mind, along with foldable lenses in the 1990s and toric lenses in the late 2000s, I think having a presbyopia lens without compromising visual quality is one of the seismic leaps forward in IOL designs. Thank you very much.
Thank you so much, Dr. Black. I think that was an excellent talk. So many myths actually and so many questions that people would have in their minds, including mine, are cleared before are cleared in the talk itself. It is very heartening to know that generally, multifocals you would avoid in cases of refractive surgery like PRK, but you very clearly illustrated that it does make a difference because the contrast gets better. Likewise, even when there is an epiretinal membrane over there, uh, most people may not want to do the multifocals or may not want to do the EDOFs, but then the fact that the real patient experience saying that it's kind of become clear except for the part which is distorted, uh, in fact gives you more reassures you that you can do these lenses even in such patients. And of course, I think the last part of the presentation, which you clearly showed that it's so much of a difference between, how you would target a myope or how you would target a hypermetrope. I think not, I mean, if you read even 3,000 pages of a book, you wouldn't understand. But if somebody makes you understand like the way you did, it's easy and quick learning. So I think it was a really excellent presentation, Dr. Black. And I have a couple of questions. For instance, it's always said in diabetics, what about in diabetics or in pre-glaucomatous eyes? What do you think is the status of the Pure C lens as of now?
So that's a great question, a question about comorbidities. I'd like to preface my answer by saying that when you're starting out for the first time, start with patients who have no comorbidities. When you're putting your first 10 or 20 lenses in, start with patients who have very healthy eyes so that you can get a very clear picture in your own mind of how well this lens is performing. And once you've got the confidence in normal, healthy eyes, then you can proceed to using it in lenses in cases like I've presented. Historically, the concern is someone who's got some kind of macular disease, whether it's early macular degeneration, whether it's an epiretinal membrane, whether they've got diabetic disease, is that using a presbyopia correcting lens was associated with a drop in contrast sensitivity. And these unhealthy maculas do not benefit from a drop in contrast sensitivity. But if we're guided by the data, if we trust the data, the Pure C has the same contrast sensitivity as an Eyhance or the same contrast sensitivity as a monofocal lens. So I now don't think there's a contraindication to using Pure C in these cases.
So have you used in pre-glaucoma or normal tension glaucoma or in early diabetics or mild diabetics who are not that severe, who don't have PDR, etc.?
Yes, I have. In patients who have early glaucoma, where they might only have a small defect that's away from fixation, in patients who have diabetic retinopathy but no macular edema, I'm very happy to use this lens.
Okay. How about on the same in the same line, I would like to ask you, how about the Eyhance in diabetics and in glaucomatous, pre-glaucoma eyes, or with those with ocular hypertension?
Yeah, again, I think the Eyhance delivers very high quality vision. In fact, there was a very interesting article, an editorial published, I think, in the August edition of the Journal of Cataract and Refractive Surgery that was authored by Professor Filomena Robera, the president of the ESCRS. And she made a very interesting case that the new standard of care should no longer be a monofocal lens. It should be an enhanced monofocal lens, because the data shows that you get a tangible improvement in intermediate vision without any penalty of dysphotopsia, without any penalty of a drop in contrast sensitivity. So I think that you can use the monofocal and the Eyhance interchangeably.
Okay. Okay, so I think, are there any questions on the portal which we can take? Is Mr. Ashutosh there? Okay, so I think we had a great session, and everything that we wanted to know about Pure C was discussed threadbare. And I would like to thank both of you for this excellent talk, and I'm sure there are going to be views even afterwards. And of course, now they are there, but even later on, people would, want to watch and see it again. And thank you so much. And I think I would like to congratulate both of you for doing this excellent webinar on clearing the myths about Pure Sea and also highlighting all its positives. One last thing is that, do you think there is any flip side to it?
Yes, I do. And the flip side is there is only 1.9 diopters of presbyopia correction.
Okay.
It's not going to be enough for complete spectacle independence. But I think that's the only downside. I honestly do.
Okay.
And that's, in fact, that's
Thank you
not
so
just
much.
and that's not just my opinion. That's the data supporting that. Thank you, Dr. Sharma.
Yeah. Thank you. Thank you so much. Thank you so much. So I would like to thank Johnson & Johnson, who's sponsored the webinar and has organized the logistics. And I would also like to thank the audiovisual team who's managing it at the back. And of course, thanks to both the speakers today who've really done a phenomenal job. And we have completely discussed the new presbyopia correcting lens, absolutely threadbare. And I'm sure this is the lens which is going to be there of the future. Thank you.
Thank you, Dr. Sharma.
Thank you.